All right, we'll go ahead and start things off. Welcome to our webinar, Pathophysiology of Obstructive Sleep Apnea, a colorful introduction to dental sleep medicine. My name is Anna. I am an application specialist for our Invivo software and platforms. I am joined by one of our esteemed Invivo enthusiasts and clinical advocates, Dr. Douglas Chenin, DDS. If you are unfamiliar, Dr. Doug Channon is a graduate of the University of the Pacific Arthur A. Dugani School of Dentistry. Dr. Channon worked directly with Anatomage, now Osteoid, during its first 5 years as the Director of Clinical Affairs, where he helped in the development of the Invivo imaging software and the surgical guide system. He also worked in conjunction with Beam Readers, Inc. for several years, directing their implant planning consultations and surgical guide facilitation services. He has earned a reputation of a CBCT technology expert with his extensive participation over many years in various study clubs, seminars, conferences, and his numerous professional publications about CBCT imaging for various dental specialties. His primary focus now is his dental practice, San Francisco Dental Sleep Medicine, which is limited to the treatment of obstructive sleep apnea with oral appliance therapy. A little bit about us here at Osteoid. We are a pioneer 3D imaging software company specializing in the Invivo software, dental services, and cloud platforms. Originally created in 2004 under the name Anatomage, now Osteoid, our Invivo products and services have continued to be the standard in the 3D digital dentistry community. As your co-host today, we are excited to dive into our agenda, where we will discuss the foundations of sleep medicine and terminology, explore the role of CBCT imaging within dental sleep medicine, and review the diagnostic capabilities and limitations of 3D airway imaging. Now, before we get started, there are a few housekeeping notes to mention. We will have everyone muted during today's session. Feel free to jot down any questions that you have in the Q&A box. We will be saving some time at the end to answer these questions. And any that we miss, feel free to send them to us at info@osteoidinc.com. Now, without further delay, I'll go ahead and minimize my screen, pass things off to Dr. Doug Channon.
I'm just starting with the presentation slide. Can you guys see me okay, Anna?
Yes, absolutely. Thank you.
All right, great. Well, thank you for having me. I'm excited to jump into this lecture and explore cone beam and dental sleep medicine and talk about what I've learned and helped develop and what I do, and go through any questions or concerns if we get through all the material. I had initially over 100 slides, and I got it down to about 80. So some of them I'm going to go through pretty fast so that we can get through it all. But normally I do this lecture in almost like an hour and a half to two, but I'm going to shrink it down and go through some of the non-cone beam stuff a little bit faster. But again, I'm really honored to be here and to present, and let's jump in. So learning objectives, Anna just mentioned this, but we'll just go over again. I'm going to discuss some of the foundations of dental sleep medicine. And this is what we'll probably go through a little bit quick because I want to get to the cone beam side of it. And that's where we're going to get to 2 and 3 of our learning objectives, which is exploring the role of CBCT imaging within dental sleep medicine, what it can do, what it can't do. And then we're going to look through a lot of craniofacial anatomy that lends itself or causes or contributes to OSA. And I think that's going to be the fun part of this for everybody clinically, is to just get a big introduction and colorful display of all the anatomy that lends itself to sleep apnea. And so you gave me a nice intro. I had that in my slides too. I always when I present this lecture, sometimes I don't get as nice of an intro. So just a real quick review. I've been involved with cone beam CT for over almost 20 years and started off with Anatomage, now Osteoid, as the Director of Clinical Affairs. And this is where I learned everything about 3D imaging and really got introduced into dental sleep medicine with airway imaging. And so one of my responsibilities and tasks was to explore the airway and figure out things that we can do with the cone beam to visualize it and to help with the treatment of OSA. And so I got involved in a number of different research projects, software development tools, and that kind of led me on my path into dental sleep medicine. After working with Anatomage directly for about 5 years, I went on to work with Beam Readers doing implant planning. So after helping develop the surgical guide, I started to help implement it and plan cases with other doctors and facilitate that service. And during this time, towards the end of this, is when I discovered that I had sleep apnea. I was snoring and snoozing and waking up fatigued and unrefreshed, and I was gaining weight. Mental acuity was going down, and just had a lot of the signs and symptoms. And the snore was really prominent, and tossing and turning, waking myself up. And so eventually, I did a home sleep study, found out I had sleep apnea, and was like, oh my gosh, like I need to treat this. And so knowing about it, and I had already gone to a lot of the lectures and courses, I made myself a device. And I was one of those cases that like had immediate, complete, like almost relief of like all the symptoms. It was quite miraculous, actually. So the tossing and turning stopped, the snoring stopped. I woke up refreshed like immediately. Even the first day, it was really dramatic. I had one of those excellent, it was like a perfect. I was my own first patient, and I was the perfect patient. So it was a great start to dental sleep medicine. And it really changed my life, though. I got my energy back, mood, was able to lose weight, just all the different things that were challenging at the time that I didn't know were connected to sleep apnea. And ultimately started my own practice, focusing just on sleep apnea treatment. So I've been treating for about 7 years now in San Francisco. We have the iCat in the office, and we utilize it to help image our patients and come up with the best treatment plan, because it's often not just the sleep appliance. There is some. I actually work a lot with ENTs and get to the bottom of a lot of the nasal congestion and nasal breathing issues, and really try to reestablish nasal breathing. So let's jump in. So the first thing is just the foundations, and I'm actually going to go through this kind of fast because this is where you can get a lot of this information just online when we get into like the AHA and the diagnostics, but I will cover it. But the thing I really want to start with is the anatomy, and that's really what kind of my mission in this lecture is to show, is that sleep apnea is not mysterious. It really is rooted in craniofacial anatomy, dental anatomy, that's in our domain. And anything that causes the tongue to not have enough room in the mouth causes the tongue to go backwards into the airway space. So you're starting with a small airway, as we see here. So anything such as a retrognathic mandible or maxilla inset, micrognathic, so small, if the jaws are smaller, a large tongue, or the mouth is small and the tongue appears large, but sometimes people actually do have a large tongue. If you see scalloping, that's a sign. Inadequate arch forms, a cross bite, that, sometimes it's the soft palate can contribute, but usually the tongue and the mouth size is the main problem. Thick neck, again, this just adds more bulk to the whole area. And I put obesity last intentionally because it does have a strong correlation, but you can have sleep apnea without it, and it makes everything worse. The tongue stores fat, and so as we gain weight, the tongue will get bigger, and so the airway will get smaller. So it does contribute dramatically. But many of my patients, actually the majority, are not obese, and they're often quite surprised that they have sleep apnea because everybody they've talked to in the medical world still talks about obesity. So it is important, and we can't dismiss it because it does contribute, but it's not like the root cause. It's the anatomy that we're starting with, and we're going to go through all of that. And so kind of a cool little cartoon picture of kind of like that last slide. Sleep apnea, everybody talks about, your throat's closing, and then they kind of just leave it at that. The airway's closing at night, and they don't really just say that it's the tongue all the time, but that's really what it is. It's the tongue. The soft palate can get sandwiched in between the tongue and the back of the throat, but the collapsible part of the upper airway is the back and the base of the tongue, and the tongue is massive. What we see of it's just the tip of the iceberg, but when we're sleeping and relaxed, the mouth can open. And this cartoon on the right doesn't quite do justice to the mandible position. The mandible actually drops quite a bit, and the tongue and the whole base of the tongue falls back. And snoring is when the back of the tongue is fluttering there. Sometimes it's the soft palate kind of sandwiched in between. But it's, again, the tongue is the main troublemaker that starts the problem, and other anatomy can get involved. But very clearly, I always like to show, I use the same image in my office, and I just show patients like the tongue is the problem. And it's kind of like an eye opener for many patients because, again, most of the time the physicians didn't go through the anatomy. They just kind of leave it as this elusive, your airway, your throat's collapsing. And patients often come to me kind of like, wanting to get to the bottom of it. And really clearly and quickly, I can show them this picture. And if we take the cone beam, we see their tongue as well, and we can point it out. Here is an image, that same kind of cartoon image. This is actually myself. I just took a picture of myself, like a lateral picture, and overlaid it onto my cone beam to make a kind of cool looking image. And then on the right side, I rotated it. So you can see in a healthy breath, we're breathing through our nose and the air is going behind the tongue, behind the soft palate, and the mandible would be stable and closed and everything would be stable. But with sleep apnea, this is what happens. And this image is doctored. I did have to, I didn't take a scan of myself in that position. I just literally moved and kind of did some Photoshop magic here. But this is what it would look like. You can't breathe through your nose, you can't breathe through your mouth because the back and the base of the tongue are falling backwards and pinching off the airway either completely and you have an apnea. And if you snore and gasp and kind of snort, that's when you're like popping out of that. And if you're snoring, it's the airflow still going through, but it's constricted and turbulent. So I like to show this picture too, because it again very clearly shows where this is happening. And again, the troublemaker is the tongue, and the tongue often does fall back even more dramatically than that. But that's what it would look like if we took a scan of somebody if while they were having a snoring or apnea event. And so again, just that same picture, it's not a mystery. And I always like to point this out really clearly to my patients. We need to stabilize. And again, because this goes to the treatment modality, which is we're going to bring the jaw forward and we're going to stabilize it. And because the tongue's attached to the jaw, that's how this works. And then CPAP, CPAP's not a breathing machine. It's literally just pushing air pressure back there. So it's targeting the same thing. And I think that's also kind of a revelation for patients too, is that CPAP isn't this device that's targeting some other anatomy or doing something else or making you breathe or stimulating something. It's literally just pushing the tongue out of the way. And so it's the same target. The tongue is the troublemaker. So this is an important slide because it gets into the heart of the diagnostics. Sleep apnea is only diagnosed with a sleep study. You do need the full polysomnography or the home sleep studies to get a diagnosis. It's a functional test over time and not just a static image. Even though cone beam, we can really see a lot of what's happening and get an idea of what a patient might happen to them at night functionally, but we do need the sleep testing. And so I'm not advocating to use cone beam imaging as a substitute or as anything other than a tool that can really help you understand the complete anatomy and ramifications of what's happening in a patient's physiology to help treat them, because it can be multifactorial. So the sleep study is needed. And this is where I'm going to start. I'm going to go a little bit fast. This is stuff that you can find online pretty much anywhere, because I want to get into the cone beam slides and look at a bunch of cases with you. But the AHI is the kind of the number that we boil down into what gets diagnosed. And so basically, a simple way to explain this is how many times an hour are you having a breathing disturbance? And that disturbance is either complete blockage of the airway or it's a reduction, that hypopnea, that snore. So if you have 5 to 15, it's mild. And I don't like that word mild because it is definitive. And that's, 5 major breathing events per hour. That's disturbing your sleep. That's kicking you out of deep sleep or waking you up. And so it's, even though it's, quote unquote, only 5 or quote unquote, only mild, it's really not. It can be quite dramatic. And actually, kind of a side note is many mild patients actually have severe symptoms because the sleep can still be quite disturbed. And myself, my sleep apnea was actually only in the mild range, but my symptoms were very severe. So that's the AHI, and that's really a function of how many times per hour you're having a major breathing disturbance, again, from the airway being blocked by the tongue, and perhaps some other anatomy is at play, which we'll get into. Pediatric OSA, they're more strict on the numbers. So just that's the only point of this slide, is that the numbers are more strict. So children should not be snoring or gasping at all. They should be breathing through their nose. Their mouth should be closed. And if they are snoring, gasping, or mouth breathing, they can be diagnosed even easier. The numbers are not as strict with adults. And so also just to point out that children can have sleep apnea and can get and should get treatment. We'll talk about that a little bit more. RDI, so that AHI is like the major events, and the RDI is another number that adds these reras. So it's more sensitive, but it can be used just like the AHI. It's typically higher than the AHI just because they're adding these rera events, and it is really more of a true assessment of the disturbances. So a patient sometimes only has an AHI of like 3 or 4 or 5, and they're kind of borderline. But then you look at their RDI and it's like 15, 16. It's like, no, you're really definitive. Like you're having 15 disturbances because these still wake you up or disturb the sleep or kick you out of a deep sleep per hour. So the RDI can't be ignored or made light of. It's just as important. And again, often in these mild cases where the AHI is kind of borderline, if you look at the RDI, if they actually calculate it in the study, because sometimes they don't or they don't present it, so a lot of the times the RDI is higher. So ramifications of OSA, this is kind of like the pathway of what's happening. So you're sleeping, you have this apnea event, you start snoring, the airflow diminishes, oxygen decreases, and adrenaline and cortisol is released as a mechanism for the brain to wake you up. Oxygen drops, that's danger. Brain immediately reacts to that and releases adrenaline, cortisol. Heart rate speeds up. Brain's trying to arouse you. The sleep cycle gets interrupted, and you go through this sleep apnea, arousal, sleep apnea, arousal. It's the brain literally trying to save your life. Short term, it works. Long term, though, a lot of problems. Uh, Bruxin grinding, clenching can happen during these cycles. So as the adrenaline's released, a lot of the times you'll clench, and that actually also helps you get out of the event. So it turns into a learned mechanism, and then fall back asleep, and then the mouth relaxes and the jaw relaxes, and then it kind of goes over and over. If we have acid reflux, this can get involved also too. If you're totally blocked, the tongue falls back, and you're trying to breathe, but like you can't. So all the breathing muscles are still squeezing and can actually squeeze acid up. So sometimes that gets in there, and you're in a state of fight or flight instead of rejuvenating restful sleep. And this turbulent sleep puts strain on the brain and the body. Depending on how much adrenaline is released, you can see massive fluctuations in heart rate, and you can get night sweats, and cardiovascular strain is one of the biggest complications that we worry about long term. And unfortunately, it does get worse with age, typically as we lose more muscle tone. And so long-term health consequences are quite dramatic, and they can be severe with things, heart disease, hypertension. Cardiovascular implications are really big. And there's a lot of other associations with weight gain, diabetes, increased risk of accidents, and then just at the very least daily life, quality of life, that cognitive memory, mental acuity goes down, weight gain, and just the decreased quality of life. So there's a lot of short term and long term, but it is really important. And sometimes we talk about the cosmetic, the snoring, depending on what the patient wants. But really, at the heart of all of this, there is deep health implications that we can't ignore. And sometimes it is the impetus for coming in. A patient actually discovers they have sleep apnea because they have high blood pressure or something like that. So, again, I'm going through this kind of quick just because I want to get to the imaging, and a lot of this information you can find online. With children, the symptoms are different, but some are the same. But the snoring and the sleep apnea does lead to growth hormone deficiency and stunted growth, stunted brain development, learning problems, all these things that we see because they're not getting that restful, rejuvenating sleep. They're not getting the growth hormone at night, and there's a lot of negative implications of that. Typically with children, combined ENT and orthodontic treatment is the best because you can grow a child out of sleep apnea. So the oral appliance isn't what we do for children. We get them doing ENT to get them breathing through their nose again, and get the orthodontics moving to allow for expansion and growth and development of the craniofacial complex. Here is a video of a patient who's having sleep apnea, just to kind of stress the weight of it. But what you'll see is the patient is starting to fall asleep. Look at the oxygen. This is kind of just to hammer home what we were just talking about. You have the heart rate and the oxygen showing. And then as soon as the patient falls asleep, the apnea events, the snoring, there we go. We got some turbulent airflow. That's the back of the tongue falling back on the back of the airway. And even with snoring, you'll see the oxygen start to drop because it's turbulent airflow. And then now here's the apnea kicked in. So the tongue completely fell back to the back of the throat and the airway is clogged. Notice that he's still trying to breathe. The You can see the stomach moving. Oxygen's now dropping quite dramatically because there's no airflow. And it was after an exhale too. So there's the airflow, the oxygen drops quite rapidly. There's that classic position of the mouth. Again, the jaw's inset falling backwards and the tongue's falling backwards. And then now the heart rate, you can see the heart rate jumping up a little bit. There's adrenaline released. And then all of a sudden, there's going to be a massive spike of all of that. You'll see the heart rate really spike and he'll gasp and snort eventually. This is all still like not breathing. It's like being choked. There's no breathing right now. This is all complete blockage. Look at that oxygen. This is like really severe. Normally we don't see it this dramatic. This video obviously is a very dramatic one. Finally wakes up. Notice the heart rate shot up, almost got to 100. And in severe sleep apnea, that's happening over and over and over again. And so that A in the AHI, that's a really big apnea event, but that was just one. That would be counted as one. And so again, if you have just a few of those, it's quite dramatic. Normally, when we see that severe of them, though, they're going to have more than one. That's just going to be happening throughout the night. Upper air resistance syndrome. Just as a quick note, because I want to get to the cases, but if you're really borderline and you're like the AHI is like 4, you might not be given a diagnosis of sleep apnea. You might be given a diagnosis of upper airway resistance. Very similar thing. It kind of manifests though as more of a shallower breathing, not so much of those gasping apnea events like we just saw, and more of like a shallow, constricted restrained breathing. The RDI can be higher. Sometimes it's over 5, and usually then it just gets diagnosed as sleep apnea. But sometimes people will diagnose it as upper airway resistance. And so if you are borderline, the AHI is less than 5, even if the RDI is less than 5, you can still get a diagnosis, but it won't be sleep apnea. But it has a very similar manifestation. And also here's an interesting point is some patients are such light sleepers that they get themselves out of apnea events. And unless they have like a sleeping pill, they won't be diagnosed because their body has learned to get out of the events. And so sometimes these borderline cases is just patients who are like literally able to get themselves out of it. But it wakes them up. Unfortunately, the downside is this: they're tossing and turning all night long. But if they take a sleeping pill at a sleeping center, then the diagnosis becomes definitive, and that's why sometimes sleeping centers will actually use a sleeping pill. Central sleep apnea is something totally different. This is when there's just not a signal, so it's less dependent on the obstructive nature. And so, just to point that out, that we're not talking about central sleep apnea in this lecture. We're talking about obstructive sleep apnea. Treating sleep apnea, again, we just have to move the tongue out of the way. CPAP is not a breathing machine. It's not stimulating anything. It's literally just pushing the tongue out of the way, or the soft palate if that's part of it. And then same with the oral appliance. By stabilizing the jaw, because the tongue's attached to the jaw, we move the jaw forward and move the tongue forward and then hold it there and stabilize it there. And hopefully encourage some nasal breathing too. And that can be an effective treatment. Surgical treatments, there's a lot of different surgical treatments. The one thing I want to point out is I really like the ENT treatments to help resume nasal breathing. And some of the ones that I see less effect are like the UPPP, the palatal, uvulopalatal pharyngoplasty, unless the palate is really just a massive one. But in most cases, it doesn't help that much because the tongue is the problem. I do really like the ENT treatments though, because if we get nasal treatment, nasal breathing happening, we get the mouth closed more, and a closed mouth is a stable airway because the jaw is stable, it's not falling backwards, and thus the tongue's not falling with it. So many of my patients also do an ENT for different treatments, whether it's just congestion or they actually need more treatment there. Tonsils and adenoids is comes up, and that can actually be something where the tongue is not the main culprit or it's part of it, and we'll look at some cases with that. And then oftentimes we actually do, combination treatment. Sometimes it's very severe and we need CPAP's help, we need oral appliances help, and maybe sometimes the ENT as well. So not every case is just a clear cut and dry, here's an oral appliance. Usually there's something else going on that we can do to help with the treatment. And cone beam can help show that and spot that out and then encourage patients to get treatment because everybody knows it's important to get nasal breathing, but when you have the cone beam to show them what's going on, the impetus to go get treatment and to actually do it increases. Okay, so we got through a lot of the diagnostic stuff, and this will kind of come up. And again, that's basic information that you can get pretty much anywhere online. What I want to do now, though, is get into this part, which is part 2 and 3 combined, which is exploring the role of cone beam with the anatomy that's consistent with obstructive sleep apnea. And so the value of cone beam in dental sleep medicine is massive. It doesn't, again, give us that diagnostics of the sleep apnea. That's the sleep study. But it shows us everything that's happening and what's around it. Again, it's not a functional, so we're not seeing exactly the airway closing or where it's happening. But when you take the scan, you're going to see what's happening in the nasal passageways, the sinuses. If there's problems with the TMJ, we're going to check for the swollen tonsils, adenoids. So we get to see everything, and then the small airway shape too, if that's part of it. Cone beam, again, not diagnostic. It gives us the best case scenario, and so in most scanners, we're upright, and so it's even you'll still see the airway, compromised. That's actually the best case scenario. So it is a great insight into what their anatomy looks like, but not necessarily how it will function. But in many cases, though, it's pretty easy to see based on the anatomy what's going to happen based on how constricted they are. And so I use cone beam all the time on every patient, and it gives me an assessment of the severity of the airway obstruction. It gives me a view of the nasal passageways, just the general skeletal classification. I get to look at the jaw joints, the TMJ, and also just look for any other pathology. Sometimes the most common is tonsils and adenoids, even in adults that comes up. So the first one, the airway obstruction, is what we can really see very clearly. And I always like to look at that sagittal slice. It's that same picture of that cartoon. And I use this a lot to educate and show patients what's happening and why the oral appliance is going to help them and really point it out. There is some research on this. And so this is actually pretty neat. And this is where the Invivo software can help, where you can actually get a measurement if you want. Again, this is not diagnostic, but there is risk correlations. And so there's been multiple studies that show that this minimal cross-sectional area, when it's a certain value, will have a higher risk. So we can definitively say that there is a higher risk. Can't diagnose it, but there's a higher risk when there's one of these values. And this also, again, is just a great image to show patients and elucidate that their airway is compressed because the tongue's fallen into the airway space, and educate them on that. Cool video from the software just showing this again, that indention going back is the tongue pushing into it. Soft palate gets pushed up a little bit at the top part, but that back and that base and that deep indentation is the back and the base of the tongue. So again, the tongue is the troublemaker here. That's one of my big points I'm always trying to make. So rules of thumb, if you do this airway measurement in the software, high risk would be, lower than 50, moderate risk 50 to 100, and then low risk 100 to 150. And these are just to kind of give you some numbers and visuals, even sometimes even just the visual, the color code, it gives you an idea if there's a risk associated. But anytime you see a compromised airway like that, there can be some risk of it. And just another little point here, if you're scanning people under 20, the numbers are a little bit different. The minimal cross-sectional area should be about 10 times their age. And so if they're really young, those numbers won't match up. You have to use this 10 times the age principle. And then also just the shape. In sleep apnea, we often see the airway more ribbon or oval as opposed to like a perfect cylinder. And so sometimes just looking at the shape, you can get an idea. And even that color code, without even knowing what the number is, the color code visual in the software is really good. I like that. And then also the patient education, of course. So look at the minimal cross-sectional area, but also don't let it be the only thing that even if you have a big airway, you can still have sleep apnea, and I'll show a case like that. And you'll see this even in I point this out just because the you'll see this in radiology reports. If you get the radiology report, they'll actually mention that this patient is at higher risk for sleep disorder breathing because of the anatomy. And this is, class 2 patient, the jaw's inset, the tongue's pushed back. Soft palate's pretty big on this case, but the heart and the main problem is the tongue. So this is a neat slide. We don't scan patients all the time pre and post, but this was a research project. And just to show what happens with an oral appliance, when you bring the jaw forward, the airway actually opens up in all dimensions. You actually get a lateral increase, an anterior posterior increase as well. So it's not just that you're pulling the tongue forward and away from the back of the throat. You actually do get an expansion all around. It's probably due to the palatal pharyngeal and palatoglossal muscles moving laterally and opening up. But we do see a dramatic increase in the airway shape and size in all dimensions when using an oral appliance. And again, this is a scan pre-post with an appliance. And we don't do this on patients regularly. This was, again, for a research project just to show what it does. A follow-up sleep study is what you do to test treatment outcomes. So in some cases, this is a patient who, when they first saw the ENT, they were told, oh yeah, you need the UPPP surgery, and that's going to help you with your sleep apnea. And it probably will help a little bit, but look at the tongue, look at how big it is, the back and the base of it. This is a case that will not be successful with just the UPPP treatment. And I treated him with an oral appliance, and we got really good results because you could see it's class 2 and deep inset. We needed to open up the airway space. So this can also help a patient if they're kind of deciding to do one of these surgical treatments. When you see this type of a constricted airway, you're going to need much more than just sculpting the palate in this particular type of a case. Here's another one, the opposite, where soft palate is pretty big, but the airway looks really big as well. This is sleep apnea. Still, it's kind of a really elusive case. And again, this is why we need the sleep studies and just symptoms and reports from the patient. There was snoring and gasping and tossing and turning. If you look closely, the maxilla is a little bit inset. It's kind of like a subtle micrognathia, subtle retrognathia type of a case. And there is narrow arches, hard to see in this picture, but the maxilla doesn't fit well over the mandible. But all of that combined with the mouth breathing and the nasal congestion leads to sleep apnea because the mandible can actually fall pretty far back. So point of this case is don't let that minimal cross-sectional area in a big looking airway rule it out, again, because it's not diagnostic. It just points out some patients who are at risk, but it doesn't catch this type of a patient. So you have to look into more factors. What's really neat about again, we're kind of on this topic of just the airway itself with cone beam. You can use it for the diagnostics of swollen adenoids and tonsils. So again, not saying they have sleep apnea because of it, but this does just for the diagnostic of this particular problem. So on the left, we have severe swollen adenoids in a child, and naturally look at that tongue. It's kind of has a low tongue posture, most likely because this patient's breathing through their mouth at nighttime. They have to. That's going to get clogged when they try to breathe through their nose at nighttime. And then same thing. What do we have here? Sample case, so another pediatric case with the adenoids, swollen adenoids, and often we do see this low tongue posture and kind of already a class 2 development. That low tongue posture, it's just not flush with the roof of the mouth. I don't tell patients what to do with their tongue when I scan them because I want to see if they do this when they're just sitting there. Do they naturally push their tongue up and forward, or do they let it drop down and back? That kind of tells me a little bit about what they do at nighttime too. And you can see in the cross section to the left, the tongue also isn't flush with the roof of the mouth. Adults, this can happen too in adults, of course. So the swollen adenoids often is a sign that they've been breathing through their mouth. And then when you look at the scan, look at that cross bite, so the mandible's underdeveloped, the maxilla and the mandible because there's crowding there, but the maxilla more, and that's again from the tongue not expanding the maxilla during growth and development, most likely from mouth breathing. And we talk about that a little bit more in a second. Palatine tonsils can be the problem, can be the cause of sleep apnea. So I'm always saying the tongue, but the tonsils really can be. And in some cases, when we have this type of a case, that they just need to be addressed. And this patient, if we did a sleep study on them, would most likely be diagnosed with sleep apnea just because there's going to be a decrease in airflow. Just a bigger picture of that. They're actually touching. Oh, this is a different one. So, or maybe the same one. Kissing tonsils. They're actually touching and massive. Cool 3D visual of this from the software where we see the tonsils pinching in laterally and then also the adenoids at the top. And so this airway's compromised in multiple dimensions. And then that's the best case scenario. Then they sleep and relax. They breathe through their mouth and the mouth opens and falls back. And now the tongue's going to push it back even further. So it gets pinched in from all sides. And so children with swollen adenoids and tonsils are often mouth breathers and then have even further problems during the night. I'm going to skip this video. It just shows a child snoring and then not snoring after they remove the tonsils. You can find those online. But quite dramatic. And so children should not be snoring. They should not be gasping. They should be breathing through their nose with their mouth closed. And this comes up in adults too. This is one of my patients. We often see these just go untreated for many years. And so don't be surprised if an adult comes in and they have this as well. This patient didn't want to do the tonsil removal, and we just did an oral appliance, and we got good results. Oh, got kicked out of there. We go. We got good results with that, but would have been better had we been able to surgically remove the other obstructions with the tonsils. So this is another interesting point. This might be kind of a neat thing for some people if you haven't been exposed to this, but mouth breathing and jaw development is really the heart of why most people have sleep apnea. Early on in life, if you can't breathe through your nose, and you're breathing through your mouth, your tongue is now down and back, and it's not pushing the jaws forward and wider. And so the tongue is a driving orthodontic force in our growth and development. And it comes up over and over and over again when you'll see class 2 or crossbite or, maxillary deficiencies. All these different things go back to mouth breathing, 3, 4, 5, 6, 7 years old. Sometimes it's just from asthma, allergies, an accident, a cold. But if you get into the habit of mouth breathing, we see this dramatic lack of growth and development. And so unraveling a lot of patients' sleep apnea and nasal congestion issues goes back to some mouth breathing as a child. It's another image. Oh, tongue tie can contribute to that as well, just because it's holding down and back as opposed to being able to go up and forward and push the arches. So nasal breathing is a missing link in all of this. I just talked about this a little bit, but if you can't breathe through your nose, your mouth's going to be open, and then the tongue's not driving the growth and development, the expansion as it's supposed to. And then also, as we get older, it just kind of snowballs on itself because now we're breathing through our mouth. The mouth is open, relaxed, and falling backwards and destabilized. And so treating patients with an oral appliance helps the mouth and the jaw stay closed and forward and not fall back, and the tongue not fall back. But if we can get nasal breathing, the treatment's even better. So cone beam can be diagnostic for a lot of the different things in the nasal passageways, and that's probably where I spend most of my time with patients, because every other case that comes up has some sort of sinusitis or other problems. So here's a really big one with just pansinusitis, and you can see those nasal passageways are just completely not clear, and even the maxillary sinuses are full of gunk. We see a lot of deviated septums and just thin nasal passageways. This one, actually, you can see it kind of kinking off to the right on the left on the X-ray, but right for our view. And then another one little deviated septum there, but really thin nasal passageways and big turbinate. Patient's left, but our right, that turbinate is enlarged, and that nasal passageway is really small. There's a nasal cycle, so it goes left to right, so they'll be kind of bigger and smaller, but that's way too small on that small side of the cycle. And then here's a case where they're just completely the turbinates are enlarged and the nasal passageways are really thin. And then when you lay down, usually fluid builds up a little bit. And this is the type of patient that just can't breathe through their nose at all. I see this all the time. Every other scan looks like this in the cone beam. We often do different surgical treatments. Septoplasty, turbinate copulation. This is a case of mine where we did the septoplasty and the turbinate reduction actually at Stanford. This is a pre-post superimposition, just showing the change in the airway or in the nasal passageways. Same case, just looking down, you can see the straightening of the septum and the reduction of some of the turbinates and the opening of those nasal passageways to allow this patient to become a nasal breather again. And so sometimes to reestablish nasal breathing is not as simple as just, taking some nasal sprays or meditating on it. Like, you really have to do some surgical work. And sometimes it's as dramatic as septoplasty, but sometimes it's as minor as coblation, the radiofrequency ablation, where we can simply shrink the tissue. I'm going to go through this section pretty quick. The main point I want to make about this is that most patients are, not most, I shouldn't say this, but a lot of patients with sleep apnea are hidden class 2s or like hidden micrognathia, hidden retrognathia of both arches, and you don't see it because they had orthodontics. So the teeth look nice, they look like they're in class 1 positions, but when you assess the jaw structures, they're micrognathic and retrognathic, and usually mandible and maxilla. And so the cone beam can kind of pop this out. Of course, there's the clear ones, which clinically you can see, and then you're going to see it in the cone beam. But there's a lot of cases that look good clinically, but then when we do the cone beam, it's very clear that the mandible is retrognathic, or the maxilla. The maxilla is often a problem in these cases. Crossbite comes up all the time. And again, that's from that mouth breathing and the tongue not pushing the maxilla laterally during growth and development. So I do see a lot of these deep palates, which also unfortunately decreases the nasal floor growth and development too. So they usually have nasal breathing problems. That's part of the beginning of the problem. So these things just keep spiraling themselves. So if we can't breathe through our nose when we're children, the nose doesn't grow as much with the same orthodontic problems that happen. And so we do see deep palates a lot. And sometimes it's very subtle, like this case where there's just some crossbite, but it's usually there. You can get into really advanced cephalometric analyses, which is really neat now with the AI auto one. This is super easy. You just press the button and it traces for you. And so it is kind of neat to get those values and numbers for the skeletal relationships. Again, because I see on adults, I see a lot of children, adults who were treated orthodontically, and they come in presenting as class 1 occlusion and bites, but skeletally they are not. And that's really interesting to see because, again, sometimes they don't get spotted by maybe the regular dentist or the physician. They're like, yeah, you don't have that inset mandible that we heard about, which is great if the physician's looking for that, because usually they're just looking for obesity. But if they're actually looking at the dental anatomy, sometimes it's camouflaged by the orthodontics that they've had. And big point here is I have patients who have sleep apnea with all dental classifications. It can be class 1, class 2, class 3. Class 3s are often hidden retrognathic maxillas. So the mandible being forward, you would think that, gosh, their airway is going to be, massive because their lower jaw is so far forward. But it's often that the maxilla just didn't develop, and so the tongue and the soft palate are still pushed backwards because of the maxilla. And so we see this all the time. But you could basically have a sleep apnea case with any skeletal classification. So there's no real rule of thumb. I mean, class 2, the retrognathic inset mandible is a rule of thumb. But any dental deficiency, whether it's maxilla, crossbite, narrow arches, anything that lends itself to less room in the mouth for the tongue has nowhere to go but backwards into the airway space. And so you can have compromised airways regardless of what deficiency there is. whether it's class 2 or class 3 or perfect class 1. So that's something to be aware of. Just pointing this out, everybody knows this now. A lot of the orthodontics now focuses on expansion and growth and development as opposed to extraction. So airway-friendly orthodontics, or I should say actually, anti-sleep apnea orthodontics, because you can grow children out of it, is usually done with expansion and growth and development instead of extractions. And sometimes, of course, with more advanced surgical intervention if needed, like MMA. Okay, we got through a lot of that. We got a little bit more. We got some time. I'm going to go through this. Actually, we got a good pace. I'm going to keep up the same pace, and then we'll have some time for question and answers. Again, now cone beam, we were able to look at the airway, we were able to look at the nose, we were able to look at the orthodontic assessments, the jaws, and now going up further into the jaw to the TMJ and also the cervical vertebrae. But it's nice to be able to look at the jaw joints because a lot of sleep apnea patients have TMJ issues because this is part of the same complex of problem. It's a growth and development musculoskeletal problem at the heart of all of this. And so if they didn't grow, if the mandible didn't grow into the right position, the condyles are also usually not ideal as well. So not every case has a TMJ component, but many do, and it can be very subtle, or it can be quite profound. And so if you send in a case for a radiology report, you might just see something very simple like some functional remodeling. And if you look on the our left, you'll see like a little bit of the flattening of the condyle on that left side. Nice cortical boundary, but just evidence that there's been some wear. And then, or all the way to jumping into a case like this where there's actually some active DJD going on. And these are the kind of the more scary ones, and they present more often than you would think. Patient with just really compressed condylar position, and these do come up. And insurance-wise, the insurance companies, there's different rules of thumb. Like technically, like if someone doesn't have stable TMJ anatomy, they're not a good candidate for normal appliance. But at the same time, that's how you treat them. You treat them with a splint. So if they have severe active DJD, you got to give them a splint to decrease the compression. But then there's institutions that say we shouldn't be treating it with an oral appliance. So there's a little bit of a disconnect in cases like this. But again, as we know, with patients with massive severe TMJ issues, we do need to stabilize it. And the stabilization is a splint. And so if they also have sleep apnea, the splint could be an oral appliance, but tread lightly because there is a contraindication in that. But if we do treat the patient, we can stabilize the joint. This is just a before and after of a case that we treated where we stabilized the joint and proved with a post-operative cone beam that the remodeling had actually taken place, cortical boundary was reestablished, and the patient's sleep apnea and DMD issue was treated. And then just another sample of another TMJ case. I wouldn't get too scared about TMJ. I just went through that fairly fast just to point out that cone beam allows us to see it, but it is a component of a lot of cases, and in many cases you'll find have some compression of the disc, some popping, some clicking. There's generally something happening. The main thing I'm looking for, if we go back, is actually these destable breaking of the cortical boundary. So it shows that something's really active, and that's where you need to really be careful with the treatment plan and what you're doing, because there's an active degeneration happening. Very rarely something comes up in the cervical vertebrae, like this one, the spondylolisthesis, where the vertebrae is actually positioned more forward, so it actually pinches in the airway. So this has a sleep apnea correlation slight, but the tongue's pinching in, coming backwards, and the vertebrae is pushed in forward, or you can get curvature of the vertebrae. There actually is a fair amount that you can see. So just an area I just point this out as an area to look at, because sometimes something's there, and rarely you'll actually find different things like other problems in the vertebrae as well. Comes up actually. Well, things come up quite common. Whether you need to do something about them is pretty rare, though. Usually it's just to note it and watch. But every now and then there's actually, like in beam readers, they'll find a broken neck that they're like, oh my gosh, like this patient literally has a broken neck right now. So go to the hospital. And what have we got here? So, just a point about bruxism and sleep apnea is that oftentimes patients will have TMJ pain and get relief with an oral appliance because they're compressed and clenching from the apnea events. And clenching and bruxing do help relieve sleep apnea. And so it turns into a learned behavior because when you bite down and clench, you flex the muscles, you bring your jaw forward, and you can open up the airway a little bit that way. So it turns into, for some patients, it can turn into this vicious cycle where they have the apnea event, they clench and grind, and then it gets out of the apnea event, they relax, they go back into the apnea event. So all night long, they're going back and forth into this apnea clench. And so you can get some pretty extensive wear on the joints. And that's why oral appliances can actually relieve TMJ. So oftentimes when patients ask about side effects, TMD being a side effect of an oral appliance, it's actually, in my practice, it's more common that we get relief with treatment. Complications can come up with the jaw joints, but usually we actually get relief of the TMJ issues and headaches and different things associated with clenching and grinding. And this is just a patient with massive masseters, and I think learned how to kind of control the sleep apnea a little bit by clenching and grinding, again, to flex the muscles and get out of it. So you see a patient like this, and just by the shape of the jaw and the tongue, I mean, everything in there, there's so many signs of sleep apnea in just these two pictures. And then rarely, this I just mentioned briefly, and then we'll get into some questions and answers. But also general diagnostics. Things do come up, random things that you wouldn't expect, and that's where cone beam can be really valuable if something totally unexpected comes up in the scan. And it does happen from time to time. And I do use radiology reports quite a bit, not on every case, but if I don't know something and it looks unclear, I send it out because then it's a learning tool for me, the patient's covered, and we get a nice report. And some doctors like to get every scan read. I think that's great. And some do it on a kind of per case basis, but we do need to look and read and go through all of them. So just a point there that the radiologist can be part of your team. And as a dental sleep medicine provider, it's actually nice to have the radiologist weigh in and point everything out. And if you're trying to get compliance for treatments with ENT treatments or other things, it can be an encouragement. So big summary. There is limitations of the role of cone beam in dental sleep medicine. It does not give us diagnostics. It does not diagnose sleep apnea. We need the sleep study for that. And so it's not a substitute for the sleep studies, but it gives us massive advantages. And it's an assessment tool for the airway itself, the nasal passageways, the sinuses. It gives us a diagnostic tool for oral maxillofacial pathology relating to the airway, the sinuses, the joints, the vertebrae, and just their general dental skeletal anatomy. It gives us that big three-dimensional understanding and baseline of the patient's anatomy. It can be a screening tool. So in practices where sleep medicine is the primary focus, where you're doing implants and other things, you might take a scan on someone and then see, oh my gosh, there's something happening in the airway, or swollen tonsils, whatever it might be. And then in that case, it can be a screening tool and help you find patients that you might have missed otherwise. And it's a nice communication tool as well, and patient education, both professionally for other doctors, but also just to educate patients themselves. And so with that, I think I did pretty good on time. Ended with just a few minutes, and I went through some of that fairly fast, but I wanted to get through a lot of the information and go through those cases. And so thank you for everyone who joined today, and if there's some questions, we'll go through them.
Yeah, it looks like they're just coming in here. One that I'm seeing at the top here, and I believe you went over it, Dr. Chenin, but are oral appliances only for adults or are they for children too?
Yeah, so generally we're dealing with adults because the growth and development is done, and we have the stable, occlusion and arch forms to work with. So in rare cases, you will see children get treated, but it's usually temporary. So we're pretty much talking about adults. There is devices that you can modify as the kids grow, but we're talking of usually late teenagers to adults. And
Perfect.
yeah, and actually, just as another side note, if they're that young, it's get them into a good orthodontic um, treatment and ENT treatment and grow and develop the arches, and you can reverse essentially the sleep apnea trend if they're young enough.
I think that leads into one of the other questions that I'm seeing here, which is, how much can we solve with
Mhm.
orthodontia when it comes to the airway?
Yeah, if you catch them really early, you can solve almost all of it. You catch a child, when they're 5, 6, 7, and they're starting down that pathway of class 2 development. And if you look into the nose, and there's adenoids and tonsils, and so it's usually like at this really young age, like 5, 6, 7, they need to see an ENT to get reestablished nasal breathing, and then usually get into expansion-based orthodontics for growth and development, and you can massively change and grow the airway. It's really amazing, actually. So the orthodontist can really prevent, reverse, and quote unquote cure. The word cure in medicine and dentistry is not used lightly, but the orthodontist has dramatic capabilities with really helping with sleep apnea and in many cases preventing it, just getting completely getting a child out of that growth pattern.
Perfect. One question that I'm seeing, and I may mispronounce some of these words, but it says we have begun using four-phase high definition rhinomanometry for nasal function, nasal resistance, in addition to CBCT for structure. Have you considered a 4P RM?
I haven't, but it sounds really cool. The I think any information that we get on patients' function for nasal breathing, it can be really valuable. What I try to do, even without that imaging modality or functional assessment capability, is within the cone beam and in my clinical assessments is just try to assess their nasal breathing. And usually there's something that's subpar. There's, the valves kind of pinch in, or there's resistance, or there's a deviated septum, or there's a tendency to mouth breathe. Their position, even, positional congestion when they lay down, the turbinates fill up with fluid. And so they're more congested in the nighttime and not in the day, or they have allergies. So there's so many low-hanging fruit to attack when it comes to the nasal breathing that I I don't use that what they just mentioned, but it doesn't stop me from helping patients get treatment. And oftentimes I'm advocating trying some nasal sprays if there's like turbinate. Enlarged turbinate, so it's triflonase, triazolastin, the antihistamine. Uh, Consider the radio frequency ablation to the turbinates, and in more severe cases, consider resection. But I'm always pushing nasal breathing. It is, you can really multiply the treatment efficacy of an oral appliance if you get the mouth closed and you get patients breathing through their nose. So it's definitely something that I'm always looking at, but not with that. Not with. I got to look into that. That's some really advanced imaging. That sounds really neat.
Awesome. Thank you. I think we've got time for one more. And I think it does go back to something we discussed live here, which is, what things can we specifically diagnose with cone beam and
Mhm.
what we can't?
Yeah, so the main thing we can't is sleep apnea. You can't just look at a cone beam and say, okay, you have sleep apnea. You can say you have a higher risk for it, though, and that's neat. When it gets into what can we diagnose, now we're diagnosing, pathology, swollen tonsils, or dental skeletal relationships that are risk factors for sleep apnea. So a lot of the things in our diagnostic capabilities are pointing out risk factors for sleep apnea, but not the actual sleep apnea.
Perfect. Any questions that I am going to miss here as we wrap up, I'll go ahead and have them answered via our message out here at following this webinar, or feel free to send them to us at the info@osteoidinc.com. But thank you for taking time to join us today. We look forward to seeing you again in our next webinar in December. Look for that follow-up email as well as a link to this webinar recording. And thank you for joining. Everyone have a great rest of your day.
Thank you.